Hi again, we're going to talk here about lower extremity occlusive disease. This is one of the most common peripheral vascular diseases that you're going to see. And one of the big things, like any of the peripheral vascular diseases, is that this is caused from atherosclerosis. So this is a deficiency of circulation to the lower extremity due to atherosclerosis in the vast majority of cases. There are a minority of cases, small minority of cases, that are caused by other things, but we don't need to worry about that for the USMLE. For the USMLE, lower extremity occlusive disease is caused by atherosclerosis. And so the patient population that you're going to see this in is going to be the patient population that's most likely to get atherosclerosis. So the risk factors are diabetes mellitus, smoking, hyperlipidemia, hypertension. Those are modifiable risk factors. And then non-modifiable risk factors are things like gender, males being more likely to get it than females, older age, of course, and then genetics. So this generally is going to present with a certain degree of pain. However, you don't have to have pain to actually have lower extremity occlusion. You can have atherosclerosis. All of us have a certain level of atherosclerosis, but it doesn't cause disease. So here we're talking about atherosclerosis that causes disease. So 10% of the Western population over the age of 65 is affected with significant atherosclerosis. And by significant atherosclerosis, we just mean atherosclerosis that causes some kind of disease process. And with lower extremity occlusive disease, we see this in up to 6% of patients over the age of 70 in the United States. The artery that's most commonly implicated is the superficial femoral artery, particularly as it's going through the adductor canal. You can also see it in the tibial artery and in the popliteal artery, but it's most commonly in the superficial femoral artery. So just to review the lower extremity circulation, mostly looking at the arterial circulation here, we have the femoral artery, which is coming down here past your inguinal ligament, and then it splits up into the superficial femoral artery and the deep femoral artery. The superficial femoral artery is coming down along here. Once it crosses into the knee, it becomes the popliteal artery, and then splits into the posterior and anterior tibial artery. So it's the superficial femoral artery that's most commonly affected. So that's, I guess, the most important thing to know anatomically. All right, so there are three manifestations corresponding with the severity of lower extremity occlusive disease. As far as I would remember that lower extremity occlusive disease is a disease process that can result in different manifestations depending on how severe the disease is. So in the very, very early stages, it can be asymptomatic. It is asymptomatic in the very, very, very early stages as you're developing atherosclerosis in your lower extremity vasculature. Once it starts to develop symptoms, then it's going to usually start out as intermittent claudication. And intermittent claudication is pain, reproducible muscular pain, that comes on exertion and is promptly relieved by rest, usually within minutes. And it's going to be important to know whether this interferes with the patient's lifestyle or not, because that's going to dictate treatment. So early on in the natural history of peripheral artery disease, lower extremity occlusive disease, you're going to have intermittent claudication, which is relieved by rest. And what I want you to think about here is compare this to some of the symptoms you have in your heart when you don't get enough oxygen to your heart, because that's exactly what's happening here. This is just like angina of your leg muscles. Okay, so remember that angina of our heart is where we're not getting enough oxygen to our heart at exertion, but then when we sit down and rest, it gets better. That's exactly what intermittent claudication is of your leg muscles. It's muscular pain that's relieved by rest. Now, ischemic rest pain is reproducible muscular pain that continues at rest. So this is like unstable angina. You have the pain and it doesn't go away even though you're not moving. So now with ischemic rest pain, some of the typical things we see with this is that it's exacerbated with elevation of the leg, and it's made better by putting the leg back into a dependent position. Why is that? Well, when we have our leg elevated, or if we're laying supine, what's happening is that we don't have the blood flow, the pressure pushing the blood down to the lower leg. So you don't have the pull of gravity pulling blood down. When you're laying down, everything is at the same level, and so you don't have that pressure pushing the blood down into your lower leg. So what happens a lot during ischemic rest pain, you'll see a lot of patients with this presentation where they'll say they've got pain when they lay down, or pain waking them up from sleep, but then when they sit up and put their leg into a dependent position, so maybe draping their leg over the bed so that their foot's hanging off over the bed, their leg's hanging off over the bed, then it gets better. And a lot of times, well, pretty much all the time, when there's ischemic rest pain of the leg, when you have the pain, when you have the ischemia, you're going to have paleness of the leg. But then when you put it back into a dependent position where it can get blood flow, you'll get rubor, so redness in the leg. So this is similar to unstable angina, but of the heart, just in the leg. But the thing to really remember from this is the kind of claudication that wakes a patient up from their sleep, or makes it difficult for them to sleep just because of the position that they're in. So unlike intermittent claudication, with ischemic rest pain, you've got muscular pain at rest. So it's just the same exact difference between angina and unstable angina. And then gangrene is where you have actual necrosis of muscular tissue due to hypoxemia, or due to hypoxemia with a superimposed infection. And this is usually accompanied by ulceration, color changes of the limb, of the toe. So this would be equivalent to an MI of your muscle, of your skin, and so forth. So if it helps kind of to think about it in those terms, it's exactly the same process that goes on with your heart. Okay, so what is the history for patients with the lower extremity occlusive disease? Well, they're basically history of patients that's consistent with atherosclerosis. So hyperlipidemia, diabetes, hypertension, smokers, males, older, etc. The symptoms, it's going to really just depend on the severity. So this is kind of a heterogeneous set of diseases with your claudication, ischemic rest pain, gangrene. So the symptoms really just depend on severity. On physical exam, it's also going to depend on severity. As the disease progresses, you're going to have more outward signs of ischemia. So diminished peripheral pulses, paleness or rubor. The limb may be cool to touch. You can have paresthesias. You can also have less hair growth on the limb that's affected. So whenever we see patients with these symptoms, where we're thinking lower extremity vascular disease, the best initial test is getting pressure gradients. And the pressure gradients can be obtained by directly measuring the pressures of the leg, or it can be done via Doppler studies. So usually, classically, what you see is the ankle brachial index. And what we're doing when we measure the ankle brachial index is we're measuring the ankle systolic pressure and the brachial systolic pressure, which would be in your arm, and we're taking the quotient of that. So the ankle systolic blood pressure over the brachial systolic blood pressure, and this is done in a supine position. So when you're laying down, your ankle systolic pressure should be no less than your brachial systolic pressure. Because if you think about it, when we're standing up or when we're laying down, it should never be that your lower extremity pressure is lower than your upper extremity pressure. The only way physiologically that could happen is if you're upside down. So you should always have a higher blood pressure in your lower extremities than you have in your upper extremities. And if you have occlusion, that can cause you to get a lower blood pressure in your lower extremity than in your upper extremity, because you have occlusion, and so you're not getting pressure down to that lower extremity. So a normal ankle brachial index would be anything greater than 1. So if the ankle systolic blood pressure in supine position compared to the brachial systolic blood pressure is greater than a ratio of 1, then that's considered normal in most cases, and I'll explain the one exception. An ABI of 0.5 to 0.99 would be consistent with intermittent claudication. An ABI of 0.2 to 0.49 would be consistent with ischemic rest pain. And then an ABI of less than 0.2 is significant for impending limb damage. This is a severe emergency situation if it's this low. Okay, so some differentials here. The characteristics of lower limb pain can be a lot of things, so we need to differentiate some of the other things that can present as lower limb pain. Number one being neurogenic claudication, so like sciatica. And so with sciatica, we would have an abnormal neurologic exam, decreased reflexes, positive leg lift. So when you lift the patient's leg up, if you have any kind of root pain of the nerves, you're usually going to have a positive leg lift test. So you lift the leg up that's in pain, and when you lift the leg up, it causes the pain. It reproduces the pain. With neurogenic claudication, the pain's not always reproducible with the activity, and a lot of these patients also have a history of back pain. Another thing you'll note here, assuming that they don't have any occlusion, they'll have normal peripheral pulses. With diabetic neuropathy, these patients tend to have, well, they'll always have a history of diabetes, especially uncontrolled diabetes. They'll also have more neurologic symptoms instead of vascular symptoms. So numbness, pain, which is described as pins and needles. They'll also have normal peripheral pulses in most cases. Statin myopathy is a big one, and that's because patients who have peripheral vascular disease a lot of times are going to be on statins. And so if they're on statins and they have muscle pain, statin myopathy is something you need to rule out. Most patients who have statin myopathy were recently started on statins, and they'll also have an unconvincing physical exam. So when you look at their limb, you're not going to see the hair loss, you're not going to see the paleness, and patients with statin myopathy will also have pain usually in other areas in addition to their lower extremity. If you get a CPK, it will be elevated, and the pain will remit with statin cessation. And then finally, small vessel disease. So remember when I told you that you can have intermittent claudication but also have a normal ABI? That would be small vessel disease. So small vessel disease will cause intermittent claudication, but because it's in the small vessels, you're not going to have a lower blood pressure because of the occlusion. So your occlusion is happening in the small vessels, not in the major vessels. And so your ankle pulse or your ankle pressure to your brachial pressure will be normal because your occlusion is not happening in your larger vessels. It's happening in your smaller vessels. So you'll have a normal ABI, but you'll present totally similarly to intermittent claudication. And with small vessel disease, we're going to actually treat this the exact same way we treat intermittent claudication, but these patients can't get surgery because the disease is in their small vessels, not in the major vessels. So with lower extremity occlusive disease, this goes for all of the manifestations, so for claudication, for ischemic rest pain, and for gangrene. The medical treatment, which of course we're going to do for patients who don't need surgery at that particular time, so patients with intermittent claudication, non-surgical patients, and then any of the surgical patients with intermittent rest pain or gangrene post-operatively. And for patients with small vessel disease, we're going to modify their risk factors, so smoking cessation, which is #1 most important to reduce the progression of lower extremity occlusive disease, lipid management if you're not already doing so, best done with a statin, and then blood pressure control. You also want to have them on an exercise program, and then symptom management can be done with either silostazol or pentoxifylline, and both of those are phosphodiesterase 3 inhibitors, so what they serve to do is dilate the vasculature. Similar in the same family of drugs to Viagra. It dilates the vessels. So medical treatment is taken for patients who have intermittent claudication, which is non-disabling, they don't want surgery, or for patients who are non-surgical patients, and it's also done for patients who get surgery, and it's done post-operatively to reduce their risk of having their disease progress further. And then, of course, it's also done, as mentioned, for patients with small vessel disease because those are non-surgical patients. The surgical therapy is done for patients who have intermittent claudication that's causing disablement, so they're not able to do their activities of daily life. They want major treatment. So, for instance, if you work and it's getting in the way of your work, that would be a case where you would have disabling intermittent claudication. And it's also done for all patients with ischemic rest pain or gangrene, provided that they qualify. And I'll just add that for gangrene, you're going to do debridement first before you do revascularization. Okay, so let's look at some vignettes of some patients who have lower extremity occlusive disease, and we'll determine which manifestation it is. So a 78-year-old man presents for a routine physical. He notes that he has pain in his right leg while walking his dog, which is about a half a mile that he walks. This doesn't really bother him, though, since it's promptly relieved by rest, and his wife usually walks the dog. He doesn't drink. He's smoked half a pack per day for the past 50 years. He has a medical history of hyperlipidemia, for which he takes atorvastatin. On his most previous lab work, his LDL was elevated at 165. Physical exam is unremarkable. So the most likely diagnosis here, it's going to be intermittent claudication. And this is particularly non-disabling intermittent claudication. And whether it's non-disabling or disabling is really not a clinical call. It's based on what the patient has to say. So if this guy said that I really want to walk my dog, this is bothering me, I can't do the things that I like to do, then it would be disabling intermittent claudication. But for this guy, he says it's not really a problem for me. Plus, he's 78 years old, so he probably doesn't want to get surgery in the first place. So this is non-disabling intermittent claudication. You can pretty much rule out all of the other possible causes of lower extremity pain. He does have a history of hyperlipidemia, of course, which would increase his risk for atherosclerosis. He takes atorvastatin, so you may think possibly that it could be a statin myopathy. However, it doesn't say that he just started on the statin, so it's more likely that he's going to have intermittent claudication as the diagnosis. And then the physical exam was unremarkable, so we can assume from that neurologically he's normal. But it's going to be important, of course, in real life to make sure you're doing a comprehensive physical. So the most likely diagnosis here is intermittent claudication. And for this, we don't really need to do anything other than medical treatment. We don't need to go into him surgically because it's not bothering him. And it's solely intermittent claudication. And you can't really assume that all patients with intermittent claudication are going to go into further disease. There's really no way to determine whether or not that's going to happen, except for possibly smoking, and that's why we do the smoking cessation as part of the medical therapy. Okay, how about this guy? 57-year-old man presents complaining of left leg pain, which has been happening for the past several weeks. He works as a janitor at a local high school and finds that he needs to sit down every half hour or so to relieve the pain. This is becoming very bothersome to him. He smoked a pack per day for 20 years but quit 10 years ago. His medical history includes type 2 diabetes, which is controlled with metformin. 2-point discrimination is normal, and there are no ulcerations or gross abnormalities on his feet. What's the most likely diagnosis here? So this would be the disabling intermittent claudication. So this is a guy that works, and he's having his pain at work, and it's bothersome to him. So this guy is probably coming in and telling you, I can't retire for Medicare now, so he still has to go to work, and if he's having to sit down every half hour or so for 8-9 hours a day every day for 5 days a week, this is a big problem. So this guy has got disabling intermittent claudication. Of course, he's got the risk factors, type 2 diabetes, he's a male, he's a little bit older, but it's likely not diabetic neuropathy because he's got a normal neurologic exam and there's no ulcerations or gross abnormalities of the feet. Okay, so when you have a patient with intermittent claudication, this is going to be the one where you have to question, am I going to do surgery on this patient or am I going to just treat him or her medically? So the big thing is, does it interfere with the patient's lifestyle? The first patient, it didn't. He didn't have any problem with it. The second patient, it bothers him at work. That's a big deal. So if it interferes with the patient's lifestyle, then yes, we're going to work them up for surgery. If it doesn't, then all we need to do is modify the patient's risk factors, or we could also include some medications such as silostazol or pentoxifylline if that's something that they want. But if it does not interfere with their lifestyle, all you need to do is modify risk factors, particularly smoking cessation. And then, of course, an exercise plan. If it does interfere with their lifestyle, then the first thing you're going to do is establish the pressure gradient. You need to get your ankle brachial index. Now, like I said, you can establish the pressure gradient either by getting the ankle brachial index or by getting Doppler studies, but the USMLE expects you to know about the ankle brachial index. They're not going to ask you to look at Doppler studies and determine by looking at an ultrasound whether or not it's abnormal. So I would stick with knowing the ankle brachial index, but you can do it either way. So if the ankle brachial index is greater than or equal to 1, then the patient does not have large vessel disease, and so there's nothing surgically you can do. You can't do any revascularization for the small vessels. So this patient likely has small vessel disease, and so you're going to do medical therapy, modify the risk factors, and include silostazol or pentoxifylline in their medical treatment. If the ABI is less than 1, then your next step is going to be angiography. For the most part, once the patient has an ABI of less than 1, at this point, you're pretty much for sure going to be doing surgery on the patient. So the angiography is done to determine where the blockage is and to get an idea of how extensive the blockage is, whether it's a long segment blockage or if it's just a focal blockage. And after that, then you can do the revascularization. So this is a couple pictures of ankle brachial indexes being done. So it can be done, this is more, on the right here, this is more sophisticated, where they're taking the pressures at the brachial artery, at the femoral artery, at the popliteal artery, and then at the tibial artery. So you've got 4 pressures here. And then this one here on the left is just taking it for the ankle and the brachial pulses. So you can do either. But just remember that your ankle brachial index is your ankle systolic pressure over your brachial systolic pressure. With the more, where they do all four of these here, that can help with determining where exactly the blockage is. So if you've got a normal pressure up here, normal pressure here, but low pressure down here, then you know your blockage is further down. But if your pressure is low further up, then you know your blockage is further up. So that's why they do it that way. But for the USMLE, you just need to know about ankle brachial index. So here's an angiography, and this would be done after you get your ankle brachial index if it's abnormal. And you can see here that there's blockage of this artery here. I don't expect that you're going to have to read angiographies for the USMLE. Just know that it's your next step after an abnormal ABI. And this is the superficial femoral artery. And the reason that there's blood flow, of course, is because there's plenty of collaterals in the leg. But over time, you can outlive your collaterals, or it won't be enough. So here's your blockage right here. Here's another one. This is a smaller blockage, but this one's in the posterior tibial artery. So this is a more focal blockage, whereas this one was longer and more segmental. Okay. How about this guy? 61-year-old man presents for a routine physical accompanied with his wife. His wife mentions that he has become more sedentary over the past couple years and recently has started waking up in the middle of the night with left leg pain, which is only relieved when he sits up. The patient agrees that this is true. He blames it on sciatica. His medical history is significant for NSTEMI 4 years ago and hyperlipidemia, which is well controlled with simvastatin. On physical exam, leg pain is not exacerbated with passive leg lift. Left leg is relatively reddish-purple compared to the right. Left dorsalis pedis pulse is weaker compared to the right. Routine labs, including CPK, are within normal limits. So the most likely diagnosis here is, of course, going to be ischemic rest pain. So this patient, yes, would have intermittent claudication, or even maybe claudication all the time. And so the reason that this guy isn't complaining of pain when he walks is probably because he's not walking that much. He's sedentary, and that's because over the past maybe couple years, he had intermittent claudication, which then progressed into this ischemic rest pain that he has now. So the fact that he's sedentary really pushes us into the diagnosis of ischemic rest pain, that this came on gradually. And then, of course, that typical finding where the patient has the pain when they're in a recumbent position, and it gets better when they place their leg into a more dependent position. That's classic for ischemic rest pain. So the next step for this would be, well, actually, the next step would be to get your ankle brachial indexes, then get your angiography, followed by revascularization. So don't forget your ABIs. All right, and then this one, a 67-year-old man with a history of claudication presents to the ED complaining of right leg pain and numbness in his right foot. He was diagnosed with occlusive disease of his right leg last year with an ankle brachial index of 0.51. And scheduled for angiography, but he never showed up. He has smoked a pack per day for the last 50 years. On physical examination, his right leg is pale and cool to touch compared to the left. There's scant hair growth, and neither of the right dorsalis pedis nor right posterior tibial pulse can be appreciated. His right great toe is notably black with surrounding ulceration. The diagnosis here. So here we have gangrene of the right great toe and also ischemic rest pain. So we know that there's gangrene because, well, he's got a black toe, and in consort with what's clearly vascular disease, we know that that's going to be gangrene. And then we can diagnose him with also with ischemic rest pain because he's got this leg pain, as well as numbness, and these other physical findings such as scant hair growth and decreased pulses. We also can, for the most part, diagnose him with ischemic rest pain because he had an ABI last year of 0.51, and he hasn't gotten treatment. And remember, with the ABIs, ischemic rest pain is usually in the 0.2 to 0.49 range. Intermittent claudication is in the 0.5 to 0.99 range. So this guy was already in a lot of trouble last year. He didn't get his angiography, didn't get any surgery, which he was certainly indicated for, and now he's progressed to where he's put his limb in serious danger. So he's going to need amputation of the right great toe, and he's also going to need angiography and revascularization, and of course he'll probably need to get his ABIs done again. So, but definitely he'll need that right great toe amputated. It'll probably also be good to get cultures for this guy because there may be infection of the toe. Not necessarily, but there can be. And then, of course, we're definitely going to get him revascularized. So here's gangrene, and it's very obvious when it's there. So here's that. This could be infection down here. So that's why you want to get cultures, and especially blood cultures, to make sure that there's nothing bacterial going on within the body that we should probably treat. Okay, so what do we do surgically? So like most surgery questions on step 2 and 3, you're not going to need to know how to do the surgery or even exactly what kind of surgery to do. A lot of that's at the call of the vascular surgeon. What you do need to know is the medical problems leading up to the surgical problem. So when we do that arteriogram, when we get the angiogram of the leg, what we're mostly looking for there is, 1, where is the blockage, and 2, what's the extent of the blockage. Where the blockage is going to help us because it's going to help us determine where we need to do the revascularization, and how extensive the stenosis is also going to help us, because if it's just a small blockage, we might be able to get by doing a percutaneous stent placement, but if it's a large segmental blockage, then you're going to need to do open revascularization. I don't think that you're going to be asked to decide between the two of these on the USMLE, but you should know that these two options exist. But for the most part, you're going to do open revascularization, bypass, in patients that need revascularization. What are the contraindications for revascularization? 1, if they're non-ambulatory. So patients who are non-ambulatory, we can't really improve anything for them anyway. What we'll do for them is amputate if there's gangrene. If there's no adequate graft vessel, that's not so much a problem anymore, because we have the grafts that are made prosthetically. But this is another contraindication that I found that I figure I should share with you. And then if there's extensive tissue loss, obviously in that case you're going to be doing amputation. And then if there's prohibitive comorbidities, that's mostly determined by the anesthesiologist. So the region of blockage is bypassed by attaching a graft vessel that's either harvested or prosthetic from a site proximal to the blockage to a site distal, just distal to the blockage. So you're bypassing the blocked area. Most commonly, it's the greater saphenous vein that's used. However, you can also use the lesser saphenous vein and prosthetic conduits as well. When you use the greater saphenous vein, it's worth remembering, if you're working on step 2 or you're going into surgery residency, you're going to have to remember this, that you have to reverse the vein, because remember that all veins have valves, and so we don't want those valves getting in the way. So you have to reverse the direction of the vein when you place it for your bypass. The complications for revascularization include distal embolism, and that's because you're going in and dealing with an area that's got atherosclerosis, and so you can get chunks and particles of that atherosclerosis that can embolize distally, and that can cause hypoxia of the mostly of the digits of the toes. Blue toe syndrome, they call that. You can get intimal hyperplasia, that's just from the healing process. Rupture is possible, and then all of the general surgical complications. Definitely remember that debridement and amputation is always indicated for patients who have necrosis, and revascularization can then be taken thereafter. But for patients with necrosis, for patients who have gangrene, you've got to do the debridement and amputation first before you go about doing the revascularization. So this is just an example that I drew of revascularization. So let's say you have the blockage here in your, this is where it usually happens, superficial femoral artery right around the adductor canal. So this is a longer blockage here. What you would do is you would take either a prosthetic conduit or the greater saphenous vein reversed and attach it from before the blockage to right after the blockage. And most commonly, the way you do this is from the superficial femoral artery to the popliteal artery, just because that happens to be where the blockage is most of the time, at the very distal part of the superficial femoral artery. So this is called a femoral popliteal bypass. So femoral being that you start at the superficial femoral artery, popliteal being that you insert the conduit into the popliteal artery. There are multiple different kinds of revascularizations. I don't think you need to be too aware with, I don't think you have to be intimately aware of all of them. But this is the most common one that's done, just because this is the most common place to have blockage. Okay, so just to recap here, atherosclerosis is the etiology behind lower extremity occlusive disease, just like any peripheral vascular disease. Lower extremity occlusive disease is an indicator for all other peripheral vascular diseases. So you got atherosclerosis that's symptomatic in one place, you may have it in another. So you're going to want to listen for carotid bruits. You're probably going to want to get an EKG on the patient, stress test, make sure you're doing a good comprehensive physical and workup to make sure that in case there's anything else that might be asymptomatic that needs to be treated prophylactically for the future. So just remember that this is part of a bigger problem. When you work a patient up for surgery candidacy, you're going to start with an ABI or a Doppler. ABI is usually what we do because it's easier, and it's also on the USMLE more, so you should be more familiar with that. If the ABI is abnormal, meaning less than 1, you're going to proceed with an angiography. And the angiography will help us determine how we're going to do the surgery and where. Medical therapy is done for patients with non-disabling claudication, as well as other patients either before or after their surgery. The medical therapy includes risk factor reduction, exercise, and silostazol or pentoxifylline. Both of those drugs expand the vessels and allow for greater flow. So patients with non-disabling claudication can be managed on medical therapy alone. Other patients should be worked up for surgery. Revascularization can be done either via stent or via bypass. Usually it's done by bypass, but it's going to be the angiography that tells us what we'll do. I don't expect you'll be asked this on the USMLE, but just to know, with a shorter occlusion, you can usually get by with a stent. With the longer occlusion, which is more common, you're going to need to do bypass. And revascularization is the surgical intervention of choice. And if the patient has gangrene, you need to do debridement and amputation first. You don't do revascularization and then debridement. You got to get that ticking time bomb amputated off of them so that they don't get sepsis or any kind of other infection that could complicate things. So if they have gangrene, you're going to have to amputate first. Then you can go ahead with revascularization. And that is everything.